Hey everyone, welcome to the EMS Academy. For those I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I am an active member of Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the assistant medical directors for Baltimore County Fire Department. On behalf of Dr. Jeff Nussbaum in the medical director's office, Chief Nats, EMS office, EMS Training Academy staff, and Captain Lenny Stewart, thank you guys for what you do every day to help our community, and thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, a young volunteer at Pikesville, who's going to help us with our Zoom platform. The sign-in sheet to get credit for this later in the training. Ashley will put a link in the chat box. Click on the link, fill out some brief information, and get your MIM CEUs. If you have any trouble completing that form or questions about past participation or where to find your MIM CEUs, please hang out with us after the training, and we would be happy to help you answer questions. Tonight, we are super excited to have with us Dr. Rishi Kundi. He's an associate professor of surgery at the University of Maryland School of Medicine. Dr. Kundi is the chief endovascular trauma surgery, director of the GO team programs in trauma and surgical critical care at the R. Adams Cowley Shock Trauma Center and the University of Maryland Medical Center. Before we turn it over to Dr. Kundi, thanks for being here. I want to turn it over to Chief Nats, who wanted to share just a few words. Chief Nats.
Thanks, Dr. Barinholtz. I just want to thank everybody for supporting this training. It's definitely been amazing. I know we've heard a lot of good feedback. So Dr. Barinholtz, thank you for all the work that you put into this. We understand and recognize that it's super busy out there in the field. We welcome any feedback. I have a very open door policy. So please feel free to come to me anytime. And we always encourage everyone to, kind of share their thoughts, ideas. And Dr. Kundi, thank you so much for being here tonight. I've heard a lot about this presentation, and I know a lot of people are excited to hear about it. So that is all I have. Thank you.
Thank you, Chief Nats. Thank you, Dr. Barinholtz. Can I confirm that I am sharing my screen currently?
Looks good. Thank you.
Okay. Good evening. I want to thank all of you for inviting me to speak. As Dr. Barinholtz said, my name is Rishi Kundi. I'm a vascular and trauma surgeon at Shock Trauma. And we're going to talk about what we talk about when we talk about REBOA. And this is a little bit of a deep dive into REBOA, because I figured where EMS and fire rescue squads are currently, my impression from talking to all of you is that everyone has heard about REBOA, but very few physicians that I know of have taken the time to sit down and explain what it is. And so today I'm going to explain what it is. That will take exactly one slide, and then we'll go into a little bit of the evidence supporting it, so you can understand why some places use it, why some places don't. And at the very end, I will be going over a fairly widely distributed paper study on REBOA that you may be hearing about in the next few months. So before that, I want to give you a little bit of context for what you're about to hear. I did all of my training in New York, general surgery, lab years, vascular fellowship, and I came to the University of Maryland as a vascular surgeon in 2013. I was a vascular attending for 5 years, and around that same time, the Shock Trauma Center was getting its endovascular trauma service up and running. As I told Dr. Barinholtz before we started, I noticed fairly quickly that my favorite parts of my job were when I was helping out at Shock and where I was asked to come over. So I decided to go back for a critical care fellowship at GW, and I've been at Shock ever since. Every month, I will spend 1 to 2 months on a trauma service like I am this week, and 2 weeks on the vascular trauma service. We have 3 surgeons who are trained in both trauma surgery and vascular surgery, and each of us do both. So now you have some perspective or some idea of my perspective when I talk about REBOA. So REBOA, for those of you who aren't aware, stands for resuscitative balloon occlusion of the aorta. It is, and I'm not simplifying this in any way, an intravascular balloon catheter that is just threaded into the aorta from the femoral artery and inflated to occlude it. The balloon can be deployed in the descending thoracic aorta, or zone 1, or at the aortic bifurcation, zone 3. In the descending thoracic aorta, occlusion can mitigate distal arterial bleeding or maximize coronary and cerebral perfusion pressure while resuscitative measures are ongoing. In zone 3, aortic occlusion can minimize pelvic or junctional arterial bleeding. That's it. It's an internal tourniquet. That's what the big deal is about. It's just a balloon that goes in the aorta and blocks blood flow. So one of the more frustrating parts of this conversation for me has been the assumption that I am a REBOA advocate because I'm part of the Shock Trauma Center, and we do a lot of REBOA here. It's pretty indicative of the tone of the discussion around REBOA over the last few years. You're either an advocate of it and think it's going to save everyone who's bleeding to death anywhere, or you think it's completely ridiculous and it's killing people. There's no nuance or complexity to this. The discussion has gotten so contentious, in fact, that one of the primary REBOA critics, Bilal Joseph, presented an abstract at last year's Western Trauma meeting, which associated authors' financial relationships with REBOA catheter manufacturers and the likelihood that they wrote papers supporting REBOA, which was essentially claiming that anyone who published evidence in favor of REBOA did so because they were being bribed to do so by the companies producing the catheters. This is why being a vascular surgeon is relevant. I don't know what other people consider REBOA. Oh, sorry. If it's a metonym for the idea of aortic occlusion or for the concept of a REBOA service, which we'll get to in a little bit. But to me, it's just a balloon. It's a physical object. And in light of that, the fear is kind of stupid. Imagine if the same conversation was being held over just an instrument, a clamp, that articles were flying around claiming that a clamp was the secret to preventing hemorrhagic death, or that anyone who uses a clamp was hurting the patient. When you talk about it that way, it's really self-evident that it's not about the instrument, it's how and when the instrument is used that makes the difference. In the case of REBOA, that question, how and when to use it, is particularly pointed. Aortic occlusion isn't a new technique, but with REBOA, you don't need to do a thoracotomy or laparotomy to occlude the aorta. You just need femoral arterial access, which has altered the time, complexity, and morbidity of aortic occlusion. And that in turn has put us in a position of significant uncertainty. And this is a point worth repeating. It's not the physiologic effect that's new and mysterious. It's how hard it is to get there. We've seen this before in medicine when an open heart surgery went from the cardiac ORs to a stenting in the cath lab, or when a peripheral bypass could be replaced, well, again, with a stenting in the intervention suite. It makes you reconsider everything on who should get this, who should be doing it, and where it should be done. Everything changes. To use a chemistry metaphor, when you drop the activation energy for a known reaction, you don't just get more product faster, you change the equilibrium. You end up with unanticipated intermediate products, and occasionally you blow things up. To give you an idea of how intuitive an idea this is, here's the first published REBOA case report. It's 1954 out of the Korean theater. Everyone is familiar with the practice of manually compressing the exposed aorta for a period of time to control hemorrhage or to combat a hypotensive state during laparotomy. To accomplish the same result in the unexposed aorta, a balloon catheter was tested as an intra-aortic tamponade in 2 critically injured Korean casualties. I look at that picture and I immediately know it's not a modern REBOA catheter, but the only way I know that is because that is a glass syringe. Everything about the catheter itself is essentially indistinguishable from the ones that we use now. Dr. Hughes' paper discusses 2 patients. That's it. And it's usually mentioned in every REBOA discussion, but I'm actually more interested by a paper that I rarely hear mentioned. In 1989, Jerry Shaftan published his group's 5-year experience in an organized effort to use intra-aortic balloon occlusion in penetrating abdominal trauma. This is the first case series looking at REBOA in penetrating trauma. He looked at 3 groups: REBOA placed in arresting patients in the ED, in those patients who are hypotensive in the ED, and those patients who needed intraoperative aortic occlusion. All the patients with no blood pressure died on the table. 1 died as soon as they transferred her to the table, but the other 4 achieved a systolic of at least 80, which was enough to start surgery. In group 2, 2 patients died on the table, but both of them had injuries to the inferior vena cava, which the REBOA would not address. 1 died on post-op day 3 of multiple organ failure. Everyone in group 3 went into the OR with a systolic of at least 80. They crashed during the case, at which time REBOA was inflated, and they all regained a systolic of at least 80. 3 of them died on the table, and all of them also had cable injuries or portal vein injuries. 3 died later. 1 of them died 3 months later. The other 4 survived to discharge. The catheter that Dr. Shaftan used was called a precluder, which is actually a purpose-built aortic occlusion balloon. When he was in New York building up his numbers, Dr. Ronald Lowe in Oklahoma was using it on patients outside of trauma. In 1986, 3 years before Shaftan, he published his results. They used it in 15 trauma patients, 5 ruptured aneurysms, 2 patients found down, and 1 with a massive GI bleed. 2 of the trauma patients survived to discharge, and each of them had an occlusion time of less than half an hour. One of them died several days later with multi-organ failure. They had undergone aortic occlusion in more than an hour and a half. Lowe specifically mentions that, under any circumstances, ischemic damage to the kidneys and spinal cord becomes likely after 30 minutes of complete uninterrupted occlusion. We talk about tourniquets on the extremities only being allowed to be in place for 4, 5, 6 hours, after which the reperfusion injury becomes so significant that it threatens the patient's life. Well, the REBOA, causing aortic occlusion much in the same way, has a much smaller time window. We're looking at patients who died after an hour and a half, and you start seeing results of reperfusion injury after a half hour. Dr. Lowe also mentions recently we have begun to place small femoral catheters into potential patients so that if deterioration occurs, the artery will already be cannulated. This is a practice done by his group almost 40 years ago that is now being done at Shock and has been for the last few years. The late Roy Greenberg, who was a vascular surgeon at the Cleveland Clinic in 2000, described 3 ruptured AAAs that were temporized with balloon occlusion and repaired with a physician-created graft. The increased prevalence of endovascular aneurysm repair, in fact, is responsible for at least some of the interest in REBOA in the 2000s, not because balloon occlusion was becoming standard for ruptures at that time, but because the final step in EVAR requires a modeling balloon to seal the endograft against the sides of the aorta, which meant in turn that every hospital that was doing endovascular aneurysm repair was equipped with a REBOA catheter, whether they do it or not. So one of the reasons that REBOA attracts so much attention is that it's supposed to be a solution to the problem of non-compressible truncal hemorrhage, which is kind of the great white whale for trauma. So the top 3 etiologies of traumatic death among civilians are brain injury, hemorrhage, and sepsis or multi-organ dysfunction. And I think a substantial portion of the sepsis multi-organ dysfunction is actually the result of early hemorrhage. So in 2007, to give you an idea of how big a problem this is, in 2007, USC looked at more than 35,000 consecutive admissions to LA County Hospital. They found that while only a small proportion of total in-hospital deaths were preventable, 2.5%, the most common cause of these deaths was hemorrhage. Now, most of those preventable deaths occurred really early, in the initial resuscitation stage, which meant that efforts in pre-hospital care, which controlled extremity hemorrhage through widespread tourniquet training and restructuring of ATLS, wildly successful. We have done such a good job with tourniquets and not letting people bleed to death from extremity wounds. But non-compressible truncal hemorrhage, there's no equivalent, at least not until REBOA. There's no way to, in the field, start control of ongoing hemorrhage. So here we are. We have an instrument that makes intuitive sense and that replicates a known technique, which is to say, cutting a patient open and occluding the aorta from outside. We have a recognized area of potential improvement, which is the patients who are bleeding to death in the initial stages of resuscitation. We have a need. And with any surgical technique, we have a handful of surgeons, Dr. Lowe and Dr. Shaftan, who just did it. And they did it as a last resort, but they did it, and then they just published their experiences. So what questions do we need to ask to know in an era of evidence-based medicine that it works? How do we figure out if REBOA actually works? Well, we start with animal models. Todd Rasmussen in the military led the way with these experiments. In a swine model of iliac arterial injury, zone 3 REBOA, remember that's down in the pelvis, resulted in profoundly less mortality than either pelvic packing or doing nothing, with a substantial increase in the blood pressure, particularly if the animals were made coagulopathic beforehand. Now, using the same model, he used at zone 1 REBOA, that's in the chest, in hemorrhagic shock. They exsanguinated pigs, and after they bled them out, they found that REBOA inflation continued to increase aortic pressure as well as cerebral oxygenation while resuscitation was ongoing. So in this model, the animals were bled out for 20 minutes, at which point the REBOA was inflated for either 30 or 90 minutes, and then resuscitation began. It's interesting that while the REBOA and control groups could each be resuscitated to similar aortic pressures after the REBOA was deflated and the hemorrhage was stopped, the differences in cerebral oxygenation persisted to up to 48 hours after injury. So these pigs, their brains were seeing the benefit of the REBOA occlusion 48 hours after the injury, the hemorrhage, the resuscitation, when they had normal blood pressures within the first hour and a half. They also found, to echo the previous slides, that after 90 minutes of REBOA occlusion, there was a substantially higher rate of kidney injury and liver necrosis than you could see after 30 minutes. This limit, 30 minutes, is now accepted as the safe limit of total aortic occlusion in zone 1. Remember, this is exactly what Dr. Lowe had said 27 years before. The same year and in the same laboratory, zone 1 REBOA was examined in actively bleeding animals, as opposed to animals who were just made hypovolemic. The animals were given liver and spleen injuries, allowed to bleed freely for 10 minutes, and then they either got REBOA occlusion, nothing, or partial REBOA for an hour. I'm not going to talk about partial REBOA because that's an entirely different topic. After the REBOA occlusion, they then underwent damage control surgery to try to address the bleeding. This was meant as a representation of traumatic hemorrhage in humans and the so-called golden hour. You get injured, you bleed in an uncontrolled way while you're waiting for first response, and then potentially a REBOA goes up and then you are taken for definitive hemorrhage control. So all of the animals who got nothing died in the first hour after injury, which is not very surprising. They were given traumatic injuries and then no one did anything and they just bled to death in front of them. About 10% of the REBOA animals died during the free bleeding portion while they were waiting for first responders. Then only another 15% died, but they died between hours 4 and 5 after injury. The other measures of perfusion were persistently better in the REBOA group even after the balloon had been deflated, which is actually not surprising because they are comparing the REBOA group to the group of animals who had died, 30 minutes in. So this animal work demonstrates pretty convincing physiologic effects of REBOA. Other surgeons around the world were doing the same thing, and enough had used and published on REBOA that in 2016, a review included 41 articles about the technique. Most of them looked at prophylactic REBOA before planned surgery, but results regarding mortality were very mixed. I mean, this was 41 papers that covered REBOA in different contexts, some of them before surgery, some of them in surgery, most of them not with trauma at all. But the most conclusive, consistent finding was, and we've seen this going all the way back to Dr. Hughes' paper, is that there was an increase in blood pressure when you put up the REBOA. 2 years later, another meta-analysis looked specifically at REBOA in the context of major exsanguination control, both traumatic and non-traumatic, whether that's placenta previa or a GI bleed indications. And in trauma specifically, there was an apparent survival benefit. And once again, REBOA showed a significant increase in systolic blood pressure, a mean of about 80 millimeters of mercury. The discussion for this meta-analysis highlighted a point that will reappear throughout all of these studies. Nobody really knows consistently how REBOA is being used in any of these papers. The authors wrote, in most studies, it was unclear whether REBOA was used in the context of a formal damage control protocol with consistent application, or whether it was used as a last-ditch attempt to salvage in-hospital patients who are anticipated to have impending unfavorable outcome. For this reason, they had to be excluded from the meta-analysis. That was particularly true of a Japanese trauma databank study. It's worth mentioning that a few years later, another study using the same database found completely different conclusions using the same data. As far back as the Shaftan and Lowe papers, emergency REBOA was being used explicitly for patients who were going to die. Even the Hughes papers say something to the effect of, we had no other option, so we thought, let's try this. The problem, of course, is that terms like moribund and we have no other option are often very, very subjective. When I was a resident, my surgical ICU attending told me one night when I tried to call her in to the unit that any attempt to resuscitate a patient from a pH of 6.9 was futile. That patient was moribund. They were going to die no matter what. So even then, that was far from a universally held opinion. But now, at Shock and at a lot of places like Shock, 6.9 is a good starting place. If we were using REBOA in patients who are universally recognized as moribund, if we were using them in patients who every physician everywhere would know that this is a patient who's going to die, we would just be putting them up in cadavers. But what if we compared REBOA to something else that we regard similarly, something that we do as a last resort in patients who have no other option, who we think have a good likelihood of dying no matter what we do, something that we do in patients when we have no other good option? Aortic cross-clamping, open aortic cross-clamping, the open equivalent of a zone 1 REBOA. they both have a similar subjective kind of judgment. So in 2013, the AAST, the American Association for the Surgery of Trauma, created the aorta database to track aortic occlusion by any method. And this was one of the first questions addressed by the registry in 2018 and again in 2023. Even 5 years after the database was founded, it was clear that it was going to be extremely difficult to compare the two in an observational manner, because the REBOA patients were rarely penetrating traumas and were much less likely to have come in with ongoing CPR than the thoracotomy patients. Interestingly, the post-occlusion blood pressure was much higher with REBOA, and aortic occlusion was kept going much longer with these patients too, which doesn't make sense. Whether you're clamping the aorta from outside or occluding it from inside, you should have a similar increase in blood pressure. A greater proportion of the REBOA patients went on to have a pelvic binder placed. They had their pelvis embolized, or they had an XLAP performed. A greater proportion of the thoracotomy patients didn't have anything performed. The REBOA patients needed more blood products, but they had a smaller base deficit, they had less severe acidosis, and lower mortality. But really, given the differences in patient population, it's very hard for me to interpret whether REBOA was an important factor in these mortality numbers. So let's just look at the patients who never got CPR, because it's easy to, look at the patients who came in dead and got a thoracotomy, and it's, I think, a little, you're likely to undercall mortality if you include those. So let's just look at the patients who got to the hospital alive. Now we're getting a hint about how the presence of REBOA as an option changes management, because even in patients who came in similar states, the REBOA patients had a mean systolic of 64 and a mean heart rate of 106, okay? Those patients who got thoracotomies, on average, had no blood pressure, and they had an average heart rate of 12, which is, I'm pretty sure, less than desirable. This is what I meant regarding the ease and complexity of the procedure. People were still waiting, and the patients were about to arrest to do a thoracotomy. Their threshold for doing it was really significant, but there was something about REBOA that made it easier to pull that trigger. By 2023, in the aorta database, there were 3 times as many patients as in 2018, and some things were more clear. REBOA was barely used outside of facilities with fewer than 3,000 trauma admissions a year. REBOA patients' average systolic was more than twice that of thoracotomy patients. If you had CPR coming in, you were more likely to end up with a thoracotomy. If you had REBOA done, you were more likely to have aortic occlusion done by a surgeon than an EM physician, which is very counterintuitive. If you took longer to get to the hospital, you're probably going to get REBOA rather than a thoracotomy. You were more likely to live if you had a REBOA placed than if you had a thoracotomy. Now, if you did die after you had a REBOA, you're more likely to die in the ICU a little bit after you got admitted. But if you had a thoracotomy and died, it was going to be in the ED almost immediately after you arrived. Mortality was really lower in the REBOA group, and these were all true even after propensity score matching. But I think it's significant that after matching, which is after saying, all right, let's take out all the risk factors for death and let's find a group of patients in the REBOA group and in the thoracotomy group who are really alike in all of the ways that our data says is important and affects outcome, the number went from 991 to 112. It's difficult to see that and not conclude that REBOA is being done for different patients than resuscitative thoracotomy by different physicians at different kinds of institutions. Every other conclusion that this paper had, I'm not so confident in, but I am confident that these are patients who don't represent much in the way of overlap. Remember when I said that REBOA just needed femoral access and it was super easy and much easier than thoracotomy? Well, my assumption, what I said in the earlier slide, was that the lower threshold for REBOA was a result of the speed and ease of deployment compared to thoracotomy. But in this study, the REBOA group needed 21 minutes to get successful aortic occlusion, compared to 12 for thoracotomy. A retrospective analysis of both thoracotomy and REBOA that we did here at CHOC found that the average time to aortic cross-clamping was 317 seconds, and the time to zone 1 REBOA inflation was 474 seconds. The rate-limiting step appeared to be femoral arterial access, If arterial access had been obtained beforehand, even if it's just a femoral arterial line, the time to occlusion dropped by almost half and became quicker than thoracotomy. Now, it's at this point that I want to remind everybody that 31 years before this paper proved it, Dr. Lowe's group in Oklahoma had started putting in prophylactic femoral lines because they said it's probably going to be faster for us to get a REBOA in if we do need it. Now, among REBOA patients, it took twice as long to get arterial access in patients who are in arrest than in patients who are just hypotensive, which is not surprising to any of us. Percutaneous access was successful 87% of the time as long as there was any blood pressure at all. But if the patient was arresting, that rate dropped to 14%. So with that information about access, hypotension, and arrest, let's go back and interpret the aorta registry data again. Patients who got REBOA were less often in arrest than those who got thoracotomies. When they weren't in arrest, they still had higher blood pressures than patients who got thoracotomy. Attending surgeons performed more than 93% of REBOA, but nearly half of the thoracotomies were done by non-attendings, fellows, residents, emergency medicine doctors. A patient who undergoes REBOA is more likely to be at a high-volume trauma center. The aortic occlusion is more likely to be done by an attending surgeon. They are going to be far less likely to be in arrest. And even if they're not in arrest, they're not going to be as hypotensive. REBOA is happening earlier in the patient's decompensation than a thoracotomy, maybe because the operators know that it's going to be much harder to get access later. The point is this: if the setting is different, high-volume REBOA centers are low volume, the patient characteristics are different, and the treating personnel are different, then none of the papers I've mentioned so far are actually comparing a REBOA catheter with an aortic cross clamp. What they're doing is comparing different systems of care. Which leads us here, the UK REBOA trial. Published last month in JAMA, so we can look forward to rheumatologists having opinions about hemorrhage control. The UK REBOA trial was a prospective randomized trial conducted at 16 major trauma centers in England, and surprisingly, they have 16 major trauma centers in England. Inclusion criteria were age over 16 and confirmed or suspected life-threatening torso hemorrhage thought to be amenable to REBOA. There were no hard criteria regarding hemodynamics, mechanism, laboratory studies, or imaging results. The only criterion for inclusion in this study was that a doctor decided that the patient probably had torso hemorrhage that was appropriate for REBOA, they guess, at which time the patient was randomized. If the patient was randomized to the REBOA group, they were allowed to have a REBOA placed, if the clinician decided to do so. But if the clinician decided not to do so, they would still be in the REBOA group. If the patient was randomized to the standard care group, the control group, they would be given unspecified standard care that just couldn't include REBOA. Okay. The primary outcome measure was 90-day mortality. The trial ran for 53 months, and in that 53 months, 90 patients were randomized. It was stopped early because of calculated harm. Here's the headline first. At 90 days, 54% of the REBOA group was dead, compared to 42% of the standard care group, for an odds ratio of 1.58. But let's look at this more closely. Of the 46 patients randomized to REBOA, only 19 actually had the REBOA placed and inflated. That's less than half of the patients in the treatment group undergoing, the treatment. So what happened to the other patients? 9 got arterial access, but they never put in the balloon because the patient improved. 5 got access, the balloon was placed, but not inflated because the patient improved. In 8 patients, they just couldn't get arterial access, and so they stopped trying. In 3, they didn't attempt arterial access because the patient improved. And in 2, they didn't attempt arterial access because the patient deteriorated, which I really have to assume means that the patient died. So naturally, of the 44 patients who were randomized to standard care, 2 of them, that's almost 5% of the control group, got the treatment. They got a REBOA inserted and inflated. If you look at the proportions, the rate of successful REBOA deployment was greater in the control group than in the REBOA group. That's very strange. This study took place over 53 months in 16 centers, which means that each hospital, remember they had 90 patients total, each hospital enrolled 1 patient every 10 months, which means that each hospital enrolled 1 patient For the REBOA arm, every 20 months. Of course, things weren't equally distributed. The busiest center of these 16 trauma centers accounted for 20% of all of the patients in the REBOA group, and that center enrolled 9 patients. That's 1 patient every 6 months in the busiest REBOA center in the trial, the busiest REBOA center in the United Kingdom. 1 patient every 6 months, and that's not per physician, by the way. That's per center. This has not been published, but from personal communication, I can tell you that 1 physician in the study had put in 2 REBOAs in the course of the trial. 2. Everyone else only put in 1 REBOA over the 53 months. And that's not counting their experience with balloon occlusion prior to the trial, of course. None of them had any experience prior to the trial. All of the physicians were just trained on simulators and cadavers when their center was enrolled. They used a 2-day course, but then they decided that the 2-day course was too long, and so they shortened it to 1 day. So these doctors in the trial learned how to use REBOA on cadavers and simulators. And with the exception of 1 doctor, the only REBOA any of them entered into the trial was the first one they had ever put into a living person. They were also expected, by the way, to, quote, facilitate the development of a local REBOA service, quote, which means that none of their hospitals, none of the 16 busiest trauma centers in England had established protocols to integrate REBOA within the care pathways, which means that once they had the catheter in, no one had any idea what to do with the patient. And that's kind of obvious because of the 90 total patients enrolled in the trial, by the way, 90 total, 13 died within 3 hours. And by 24 hours, 27 patients were dead. That is a 30% mortality in the first day. At 90 days, 48% of the patients were dead, which again raises the question. Are the patients who were chosen for the study, remember, the sole criterion for randomization was that the physician thought the patient was bleeding in the torso and it was a situation appropriate for REBOA. Are the patients who were chosen for the study moribund? To the enrolling physicians, where the indication for REBOA, well, they're going to die soon. One of the things that is really inconsistent with both the observed mortality of both groups, as well as the idea that they were randomized because they were doomed, was that only about 1/3 of them went on to undergo any kind of definitive hemorrhage control, laparotomy, extremity vascular repair, angioembolization, anything to stop the bleeding. And that's not because everyone died before they could go to the operating room. When they did go to the operating room, they went between an hour and an hour and a half later. Fewer of the REBOA group patients went for definitive hemorrhage control, and those that did go went 20 minutes later than the control group. So, all that taken together, let's imagine a typical patient and their course. You're the patient. You sustained blunt trauma and you are taken to a trauma center, one of the UK's 16 trauma centers. You are hypotensive, you are tachycardic. The emergency room physician decides to randomize you to the REBOA group. The doctor is very excited because they've never actually placed one in a live human before. You're extremely lucky because the doctor successfully gets arterial access and deploys the balloon. Hooray! Now, either you're going to get better and the balloon is taken out, or else you are going to wait an hour and a half to go to the OR. The study doesn't mention it, but I really hope that the REBOA wasn't up for the entire hour and a half that you're waiting, because remember, in animals and in humans, there is an upper safe limit of a half hour on zone 1 occlusion. Anyway, regardless of whether you were in the REBOA group or whether you were not in the REBOA group, there's a 30% chance that you'll be dead within a day. Now, maybe you're dead because you waited a half an hour to get any kind of resuscitation. These patients presented 30 minutes before they actually started getting either standard care or REBOA. It might be the hour and a half that you waited to get any kind of definitive hemorrhage control. You just kind of sat around. It might be because you were part of the majority of patients who didn't get any kind of definitive hemorrhage control. We don't know. So it would be wrong of me to say that this study doesn't say anything. It does say something. It says that if you send an ED physician to a 1-day training course and tell them that they are then allowed to put in a REBOA unsupervised in whomever they think appropriate, they're probably going to do more harm than good to the first patient they consider for REBOA, even if they don't actually succeed in putting up the balloon, which they probably won't. It says that if that physician does this in an institution that has never done REBOA before, you're probably going to do more harm than good. And it says that if these institutions don't even think about REBOA more than once a year, they're probably going to do more harm than good. I'm a little worked up about this paper because for the next 2 to 3 years, this was in JAMA. So for the next 2 to 3 years, whenever REBOA comes up, someone is going to talk about this study. And when they do, all they will remember is that REBOA use increases mortality, and they won't understand what a garbage paper this actually is. So, am I a REBOA advocate? Absolutely, for me. I've put in maybe 50, probably a little more. I'm in a center that in the summer puts one REBOA up every 10 days. A zone 1 usually goes up when a patient's about to arrest or has just arrested. And a zone 3, after we've given a couple of units whole blood and it doesn't fix things and we have a confirmed pelvic fracture. Occasionally, there was a couple of summers ago, it became the trend in Baltimore to shoot people in the pelvis and get their iliac artery, and we used a REBOA quite successfully in 3 of those patients. Here, when a REBOA goes up, the patient is in the hybrid room for embolization or the regular OR for exploration within a half an hour. And unlike the UK, we take all of them to the OR. If you're sick enough for REBOA, you probably need surgery. There's always at least one attending trauma surgeon and one critical care attending in-house here at all times. And both of them know how to work with REBOA. So if I really want to run a true randomized control trial for REBOA, which is the holy grail that everyone has been asking for, everything I just said about my institution has to be replicated to be compared to our use. It's an instrument the effect of which is profoundly not only operator dependent, but patient dependent, injury dependent, and system dependent. So by way of comparison or even context, a couple of years ago, another paper out of the aorta registry looked at REBOA outcomes in low, average, and high volume REBOA centers. In high volume centers, REBOA patients had a lower systolic on presentation, more of them were hypotensive, more of them were in arrest. High volume centers got the REBOA in the ED. In low volume centers, they had to wait until they were in the OR for it. In high volume centers, you're more likely to have the balloon placed by the attending trauma surgeon. In high volume centers, it took 15 minutes from admission to REBOA deployment. In low volume centers, it took 35 minutes. Mortality at high volume centers was 75% that of low volume centers. REBOA was more successful with sicker patients if it was at a place that did REBOA more often. Different systems, different physicians placing them, different patients, what looks to be different indications. I said when I started that REBOA was an instrument. I didn't see what all the fuss was about. And it's not that really. It's not a clamp. It requires a lot of individual expertise and experience to use the thing, not because it's technically difficult, but because it's clear that what makes a patient appropriate for REBOA is operator and institution dependent. It requires an institutional commitment insofar as you don't just need REBOA competent surgeons, but REBOA competent nurses, anesthesiologists, CRNAs, and intensivists. You need people who understand what a REBOA patient is going to act like after 48 hours or 72 hours. How can we think about REBOA then when we want to understand how to evaluate it? I think it's very similar to transplant. Don't read too much into this. I'm not offering transplant as an allegory or even a metaphor for REBOA. But I am saying that if we are trying to conceive of REBOA in a way that's both comprehensible and practical, thinking about it the way that we think about transplant, rather than the way we think about thoracotomy or hemostat, might be helpful. A transplant program depends on volume, recipient selection, a multidisciplinary team, institutional expertise, institutional morale, and attitude towards REBOA. And by necessity, the lung transplantation program, the concept, is driven by experience rather than evidence-based medicine. It is worth mentioning that there are no randomized controlled trials supporting heart transplant, liver transplant, lung transplant. No one has randomized patients to getting a new organ or just dying of their disease. So in that spirit of REBOA being a collaborative effort, I want to specifically talk about the experience of our anesthesiologist because it's very close to how to manage a patient who's got REBOA. The patients discussed in this paper came here between 2013 and 2016, but it's worth talking about the kind of patients we're dealing with, us specifically at Shock, and I imagine the same patients that are going to Hopkins. The cases are starting with a pH of less than 7.1. The temperature of these patients in the OR is less than 34, and the lactate is on average 9.5. The surgeries took about 2 hours, and the patients only got 2 liters of crystalloid. Why? Because they got an average of 24 units of blood products. Now, are these patients who are getting REBOA here the patients who are getting it at other hospitals? I'm on a monthly conference with other centers, and I can promise you that they're not. The patients who are getting REBOA at other hospitals are not nearly as sick, but they're patients at hospitals who don't do REBOA nearly as often as we do. I'm not criticizing anyone. I'm just saying that this is a practice that is done at different hospitals for different reasons and different patients. And the deciding factor is not, the surgeon who puts it in or how fast they get the patient there. It's the institution. It's something that is ineffable because it's the result of how the entire system works. I'm going to close with this. There was a quite well-known paper that was a systematic review of randomized controlled trials that were looking at the efficacy of parachutes. The authors really wanted to know if parachute use was supported by the evidence, and they found that there were no randomized controlled trials supporting the use of parachutes when jumping out of an airplane. And they concluded that no one should use parachutes until randomized controlled trials were performed and it could be supported by evidence. So someone did it. Someone did a randomized controlled trial comparing parachute use with none, and they found that using a parachute when you jump out of an airplane actually doesn't carry a survival benefit. The groups were matched on things like a history of broken bones, acrophobia, a family history of parachute use, frequent flyer miles, but they failed to control for 2 variables. See, the parachute group had an average altitude of about 10,000 meters and a velocity of 800 kilometers an hour, but the non-parachute group were jumping out of airplanes that were on the ground and were not moving. So different contexts, different conditions, different subjects. So in the absence of sufficient data, we just have to resolve to be confident, decisive, and rational, which is a lot of what we all do. We don't have enough information. We don't have as much information as we would like, but we have to do something. And we have to do something that's based on common sense, on our understanding of the patient's injury, and the system that we are a part of. Okay, that's all. Thank you. I will stop sharing.
A lot of great information. It's amazing how difficult the methodologies are to evaluate these types of kind of terminal interventions. Thanks for all the thought and sharing what goes into all of that. One question that people may have for sure is how does this change our practice in the pre-hospital setting, right? When do we start thinking about mobilizing resources to get REBOA versus moving to the hospital? Have you guys been thinking about that, or is there any guidance?
We have. So the Go team, we deploy with a REBOA. We have not used it as yet in the field. We have used it a couple of times for inter-hospital transfer. I think it's a good tool to have for a patient who is hypotensive. And the really important thing that we need to get straight before we think about rolling this out widely is it shouldn't be a stay and play thing. Time is still of the essence. A pelvic binder is still incredibly helpful. If we can get a patient into the ambulance and on the road in 5 minutes with a pelvic binder, that's still better than waiting 20 minutes and getting a REBOA in at the scene. But there are going to be some situations where a patient is continuing to be hypotensive and it's not going to add that much time to try to get a REBOA in. The reason that the Go team deploys with it is that very often with entrapment, the situation may occur when a patient is hypotensive. We think they're bleeding into their pelvis, but they simply can't be removed. And while extraction and extrication is going on, we need the option of having some kind of hemorrhage control.
Was it deployed? Wasn't there like a tree rescue within the past year? Was it?
Yeah, we had a gentleman who was cutting a tree, and the tree fell on him and pinned him. Unfortunately, and we did have the REBOA available, and because of the nature of his compression, we were anticipating that once he had made it to the ground, we were going to deploy it. Unfortunately, when he came to the ground, he arrested almost immediately, and it was a CNS arrest from a high spinal cord injury rather than pelvic hemorrhage. We brought him in anyway, and he got a REBOA when he arrived here. But exactly what I said, no one wanted to wait. And so he was transported.
Devastating.
Unfortunate.
Questions from the attendees? Comments? So some things are rolling in. Would the ability to place a femoral line prior to the total decompensation of a patient be helpful?
Absolutely. I kind of made an oblique reference to this, but as a practice, if a patient comes in and they're maybe not looking the best or a little punky, and we know that they have a likely pelvic fracture, we'll put a femoral line in immediately. And if we can get a femoral line in the field, even better.
That's clearly the GO team. There's no providers in Maryland that are putting in femoral lines.
That's correct. Yeah.
For those who are participating, don't get any ideas. Ashley put a link in the chat for your CEUs. She'll put it in again. Click on the link, fill out some information, get your CEUs.
How is this markedly different than the thinking behind mask trousers? Well, the idea behind mask trousers was mostly to drive the blood upwards. So it would not, how can I put this? It's a way of getting more proximal arterial control than mask trousers. Balloon deployment is before the iliac bifurcation. So if you've got, the mask trousers are not fantastic for pelvic injuries. So hemorrhage from the pelvis, sure. From the leg and the low pelvis, I think it's the same thing. I think that a better approximation would really be the idea of a tourniquet rather than compression. And I think mask trousers have fallen somewhat out of favor for reasons that escape me at the moment. I can't think of them. Junctional tourniquet or aortic compression. So, very good question. There are junctional tourniquets out there. The ones that I've worked with are a little bit unwieldy. And I think the REBOA is a little more versatile insofar as if you deploy it in zone 3, you get junctional control of your femorals. And if the patient unfortunately continues to decompensate, or it turns out that they're bleeding from somewhere else, you can always advance it higher and get more proximal control. I think that the junctional tourniquet absolutely has a place for upper extremity junctional because you can't get REBOA control proximal to the takeoff of the arteries of the upper extremity. And as for external aortic compression, I have not worked with any of the external aortic compression devices. So I can't really comment on that. I haven't even read any literature. I just know that they exist.
Richie, I think that's it. I don't think there are any other. Oh, here we go.
What was the survival rate for REBOA? It really depends on, because the range of patients that were being used for REBOA was so wide, it's very, very hard to make that statement with any kind of confidence. Did anyone survive to discharge? Yes, absolutely. I can talk about our immediate experience. We have patients survive to discharge all the time. I would say the vast majority of our patients who get REBOA survive to discharge. Now, zone 1 REBOA, which, like I said, we only use in patients who are about to arrest or have arrested, our survival to discharge is much less. And part of that is because these patients, we don't put it in zone 1 until they're basically about to die anyway. Part of that reason is that as soon as you put up a balloon in zone 1, you are, rendering everything south of the diaphragm ischemic. And while 30 minutes is the upper limit, I promise you, we have seen, even after only 10 minutes, we have seen some effects of downstream ischemia. All right.
Thank you,
all.
thank you. Thanks so much. Have a great night. Get some rest.
Bye-bye.
We appreciate you. We'll be in touch.
It's been a pleasure. Thank you for inviting me.
Thank
Thank
you.
Our honor.